So it's my great pleasure to be able to introduce Dr. Kristina Hardy to you. She's our first speaker of the day. Dr. Hardy received her doctorate in clinical psychology at Duke University, and completed her postdoctoral fellowship in neuropsychology at the Duke University Medical Center. She works in the neuropsychology division of Children's National Medical Center in Washington, D.C., and in addition to her clinical work with families and children in the Brain Tumor Institute, Dr. Hardy also has a program of research focused on interventions for pediatric cancer survivors who have challenges with learning and memory. So welcome, Dr. Hardy, and we look forward to hearing your presentation. Thanks.
Thank you very much. I think this will work. Let me know if you can't hear me. I'm used to teaching undergraduates, so I feel like I learned to project and also to move around a lot because that's the only way that they stay awake. I'm very delighted to speak to you. Thank you very much to Dr. Jansen and to the planning committee for giving me the opportunity to speak. I have been working with parents and families and children who have brain tumors and other cancers for about 15 years now. And every day I feel very inspired by working with families. Certainly as a parent now myself, my empathy with parents and families has changed a lot. And I have the greatest respect and admiration for families. And I think it's wonderful that you all are coming here today to learn more about things. I also know that you're very savvy about a lot of the things that I'll be talking about. So I'm going to give an overview of some of the changes that can happen following treatment for a brain tumor. But if you at any point need to ask me a question during the talk, please feel free to do that, and I'll try to adapt. So the things that I'm going to talk about today are the changes in learning and memory that can happen following treatment for a brain tumor, and then also a little bit about why we think those changes occur, and then we'll move into the area that I'm most passionate about, which is what's been being done to help with those changes once they happen. So many of you will be familiar with the term late effects. And when we talk about cognitive late effects, we are talking about the changes that can happen following treatment for a brain tumor that affect thinking and learning and memory. And we call them late effects because you don't notice them right away during treatment, but often we don't see them until after treatment has ended. So I think sometimes families start noticing them when children have trouble learning new material in school, also when they seem to forget what they've learned. Even if they seem to have known it at one point, the next day they can't remember what they've studied or learned. Or if they work more slowly than they used to, or have difficulty finishing their work efficiently. So this may be the first sign that you have. And from a neuropsychological perspective, we see these things as we measure them in our clinic as decreased attention, impaired working memory. And working memory is just the ability to hold information in your mind while you do something with it. So for adults, the things that I feel like I notice in my working memory every day is when somebody gives me a phone number or an email address, and I have to just repeat it in my head enough so that I can write it down or put it into my own phone. For children, this is more happens in school when teachers ask you to do more than one thing at a time. So this happens all the time in a school day. Please get out your books, your spelling books, turn to page 100, and look at the box of homonyms at the top of the page. So you have to think of all of those things and keep them in your head while you're doing them. And if you have problems with working memory, you may get stuck on get out your spelling book. And so then you're trying to say, I have my spelling book, but where is everybody else? And you have to find the right page and then orient yourself to what the teacher is talking about. And that can mean that you miss the next 3 things that the teacher says. And so this can cause problems with just keeping up in the classroom. Also slowed processing speed and what we call reaction time. So sometimes survivors look like they just are slower to respond, or they take a longer time to finish things than they used to. And if you wrap all of these things up together over time, what we see is that there's a reduced ability to learn and remember things over the long term. And again, with brain tumor survivors in particular, sometimes we see a strength or preserved language abilities or verbal reasoning skills, but skills that are related to visual spatial or nonverbal reasoning, reasoning without words, those look a little bit weaker. And things that I like to emphasize to parents is that generally speaking, if you have skills that have developed before treatment, we usually don't see that those skills disappear. In children, it's more that they just don't develop skills at the same rate that other kids their age do over time. So what we see as a direct result of some of the changes that that happen at the neurocognitive level is that kids tend to have reduced academic achievement over time. A big area that we see this is in math. So math, if you think about it, combines, you have to pay attention to things, you've got to keep a lot of stuff in working memory. If you think about doing column addition, you have to add all of those numbers up, remember what you've done while you put one number down and add the next in the next column. Algebra does the same thing, right? You have to balance both sides of the equation, so this makes a big demand on working memory. And so we can see this show up in math. We can also see it show up in reading comprehension. Again, if you're reading an entire paragraph, you have to be able to remember what you read at the beginning of the paragraph as you're decoding new words. I'm not familiar with this word, so I've got to sound it out. I've got to think of what it means. And now I've forgotten what happened at the beginning of the sentence or the beginning of the paragraph. So that's why we see problems with reading comprehension. With fine motor problems or processing speed, handwriting can be slow or it can be harder to read. It can also be harder to take notes while you are listening to a teacher because you've got to remember what she said. And as you're writing, you are also maybe working more slowly, so it takes you longer to write that down. And so it's harder to remember, again, what was I finishing? What was the date I was supposed to write down? So that makes it a little harder to keep up that way too. And then, of course, all of this means that it's just harder to finish work efficiently, finish it under timed conditions. So what we also see, and this is what we've seen for years and years when we started to look at children's intellectual functioning or IQ, that sometimes we see declines over time in children who have been treated for brain tumors. And sometimes we see problems interacting with peers because all of these things are also what you need to be socially successful. So if you can't remember rules to games, if you have a hard time paying attention to a long conversation that you've had with someone, can also make it hard to be able to interact appropriately with kids. So I have a whole bunch of risk factors. Many of these may be familiar to them, but I'll go over them fairly quickly. What we know is that females, girls, have a higher likelihood of developing some of these changes following treatment. And that's not just cognitive changes, that's all late effects that can occur following treatment for a brain tumor. We don't really know why that is, and honestly, it's very different in this one instance than it is in other areas of neuropsychology when males tend to be at greater risk for things like learning disabilities and attention problems. So this is one area where it's really different from the rest of our field. We also know that children who are younger when they're diagnosed with a brain tumor are more likely to develop these changes over time. And there's a reason for that, which I'll talk about in just a minute. And we also know that the more time that has passed since your child has been diagnosed, the more likely that these changes are to occur if they're going to for your child. In addition, we know that there's a lot of factors that are related to having a tumor itself. The location of the tumor in the brain, hydrocephalus, if you have that, if you have shunt failures, all of these things are small but important contributions that can affect learning over time. And in addition, the types of treatment that children receive have a big impact on some of these changes over time. So this, we know particularly children who receive cranial radiation are at higher risk for developing late effects over time. And in addition, we have a good suspicion that there's an interaction between a child's genetics and their later development of late effects. What we don't know is exactly how that occurs or why it occurs. We just have a strong suspicion on this. And the reason why we have that is because even knowing all of these predictors of change, we can't always accurately predict who is going to develop late effects and how how significant those late effects are going to be. So we know that there must be some other piece that we don't understand well yet. So I'm just going to very briefly talk about why we think these changes occur. This is an evolving science. It's really come a long way in the last 10 years, but we don't have a clear idea about how this happens and why it happens for everybody. But what we know is that as part of treatment for cancer and the cancer itself, we think that there's damage to the small blood vessels in the brain. And in particular, some of this changes affects what we call the white matter of the brain. And you may have heard that there's gray matter in the brain and white matter in the brain. Both types of tissue is very, very important for how the brain works together. But the white matter is special cells that act as a communication. It allows information to be relayed quickly and accurately to all different parts in brain networks that work together. What we know is that children who have survived brain tumors generally have damage to white matter, and that what we know about normal development is that kids from really all the way up through their teenage years are developing white matter. It's basically as you learn new skills, you have increased white matter in your brain that allows you to do things faster and more efficiently and with better connections. So this happens to typical kids. What we think happens when you've survived a brain tumor is that your white matter development slows down so that you don't have as much of that occur over time. So we also know that the development of white matter is really important and associated with working memory and is also associated with increases in cognitive functioning for healthy kids. So we have a strong suspicion and some good evidence that when you have a disruption in the development of these special cells over time, that is partly what is impacting the skills that we can measure over time in survivors of childhood brain tumors. And in both children who have survived leukemia and in children who have survived brain tumors, we can see on brain scans that there is less normal appearing white matter in the brain, and this is also associated with changes that we can observe with our neurocognitive assessments. So we think there's a good strong link here, but this is something that is being investigated now, and we'll know much more about it in the next 5 years. So I'm going to talk just a tiny bit more about what happens with some of these specific processes, but I think I'm going to move on quickly to what we're starting to do about them. I want to just talk briefly about executive functions because this used to be just a term that we said as neuropsychologists, but now it seems to be much, much more out there, and people are more aware of what this term executive functioning means. And I like to describe executive function as organization, time management, and planning skills. So these are skills that affect everybody, and they also involve regulating your behavior, monitoring yourself as you follow through with an action, but these are incredibly important for children, particularly later on in childhood, and they're vital for adulthood. So we know that attention and working memory are part of executive function, but also just being able to problem solve something as it comes up and regulating your emotions. So frustration levels is a big part of executive functioning that we don't normally think about. And these processes can be affected when you have survived a brain tumor. We talked a little bit about processing speed, and again, this is just something of being able to respond quickly and efficiently, and it also has to do with fine motor control and how you can write, particularly for kids in school. This is where you might see that. And in addition, we know that children who have survived brain tumors have problems with their memory. This can be both visual and verbal memory over time, and I think that the interesting thing is that if you add all of this together, what we see in a lot of kids are just issues with overload. And if you can see this little cartoon, the bees are saying, it's okay, Stan, just pick one flower and start from there. And this is what I see in some of our patients that we work with, is that kids can get very rapidly overloaded. The information that they have or the multiple steps that they have to do, it's hard for them to know where to start. Or that after they start, they can say, like, I just can't see a way how I'm going to get this done. So it seems very, very overwhelming, and then kids shut down or get frustrated. So one of the things that I think we see often is that difficulties with planning and organization and difficulty with generating solutions or problem solving really impact kids as they age, because we're required to use those skills every day in school. Planning a book report, what do I need to do first? What do I need to do after I've read the book? When can I plug all that stuff in so that I can get the project done in 2 weeks without rushing and with it being complete and neat? Getting stuck, and you can see this is like the bike in the rut here, is something that really happens because I can't figure out what next to do, and I'm frustrated and overwhelmed. And this can, again, lead to a lot of conflict between parents and kids because you want to help them get unstuck, but they have a really hard time generating those solutions on their own. I'm going to just talk about what we can start to do about these things. And I think the things that I emphasize to parents is, if you are able to, shortly after diagnosis, if you feel like your child is at risk, and I would say that most of us in our field would agree that if your child is diagnosed with a brain tumor, having an evaluation as soon after diagnosis as is reasonable for your child makes a lot of sense. Sometimes this is hard to do depending on where you live, what your insurance company will reimburse or pay for, and the access you have to a good quality neuropsychological evaluation. But the reason that baseline evaluations are important is that allows us to look at changes that happen over time after your child has been diagnosed, and this is really important. In addition, if you've had a baseline evaluation and you haven't noticed any changes in your child, just watching your child and looking for some of those things. Is my child taking longer to do things? Is math suddenly a lot harder? Am I noticing that I'm giving my child an instruction and he just forgets it 2 seconds later? Those would be a clue that maybe you should go in to have an additional evaluation. But I would also underscore that it can't just be you as a parent that is looking at your child, but it has to also be teachers, coaches, other people who are helping you to look for these changes in your child. Okay, so the best thing that we have right now, or the approach that most people have access to, is educational supports. So currently this is what we call our standard of care. Most children who have these changes should be able to get some level of services and accommodations at school. And in the United States, this is called a 504 plan. That's just because of a connection with law in the United States. An individualized education plan is probably, or some version of those words, is probably what is standard across both the US and Canada. And what we end up with is services and accommodations that are very similar to what are provided when children have attention problems associated with ADHD. So what we get are children are allowed to sit up front so that they can better interact with the teacher without having to be called out in the middle of the class. They have fewer distractions. They get extra time for their assignments and for their examinations that they do in school. Sometimes a reduced workload, because if they're having to work twice or 3 times as long as other children to complete the work, that often results in a big tiredness, fatigue, and drain without actually contributing to them learning. So we try to reduce how much assignments and work that they're bringing home or even doing in class. A big one that I advocate for some children with memory problems is tests based on recognition memory. So instead of a fill in the blank, I'm trying to think of a good history that isn't totally American based. But if you would say something like, what year did, gosh, this is hard. I give this a lot. I usually say, what year did Columbus sail for the New World? And if you have to pull that out of your memory, and you're American, you may know that. Otherwise, that's hard to freely recall it. But if you give somebody a multiple choice answer bank, and you say, okay, well, was it 1632, was it 1718, was it 1492, or was it 1820? Then children who have remembered that fact but just have difficulty retrieving it from their memory are more likely to be able to answer that correctly and show what they know. In addition, breaking things down into small steps can prevent that overload that we're talking about. So teachers, instead of giving your child 7 things to do at once, may just say, here's the first thing we're going to do, and you work on that, and I'll come back and help you with the next step when you're done with that. Organization, time management, and planning strategies, helping kids know how to break a long-term project down into small parts, put those parts in the right order, figure out how long each step is going to take, and figure out how to put that step in their schedule so they can get it done on time is extremely important, and it has to be taught. In addition, help getting started, sometimes assistive mechanisms like a spell checker, a keyboarding, all of those things that are available for kids who might have motor difficulties. There are other strategies that are available, stressing listening and speaking as much as reading and writing for children so that you get information in multiple ways. I usually say books on CD are really important. I don't view that as, cheating for kids, but really just helping them by getting the information that they're going to read and helping them also learn it in a different way. Sometimes voice recognition software for a computer. This has not only come down in price, but become much, much easier for kids. So if your child has either fine motor difficulties or has a problem just getting ideas out on paper, then using voice recognition software, a child can start to write a report simply by talking into the computer. And then they can get a rough draft down from which they can edit later on, and this is often very helpful. And for older students, allowing them to start to become independent with some of this by making good use of electronics. There are literally 500 applications that will help with tracking assignments, helping you to do all of these plans. Many of them are free, and you just need to help your child identify and practice them. Okay, so even though educational supports are sort of our mainstay, our standard of care, what we can offer to almost all children who have changes, there are some difficulties, and one of them is that we know that these are effective interventions for children who have other learning difficulties or attention problems, but we don't have a lot of evidence that these are effective in improving academic outcomes for children who have survived brain tumors. So this is the one big strike against this, is that we're not really sure how it works. We have a good idea that this is helpful for kids, and it almost certainly doesn't hurt kids to have this, but we don't know how much it can lead to better outcomes. In my clinical experience and many of my colleagues in the United States, we see that sometimes from school to school, even from grade to grade within a school, that the availability and the success of the implementation of these school-based services is inconsistent. If you're a parent, I hear this story all the time, that parents feel like every year I've got to re-explain what goes on with my child. I have to re-ask for these accommodations. I might have to, once your child gets to middle school and you have 6 teachers, you might have 4 teachers that are on board, and then there's that one teacher who doesn't believe that your child needs anything and is resistant to offering it. And so this happens year in and year out. In addition, I think it can be difficult sometimes if your child has very, very mild changes to get services in the first place because they may not fit into a neat category that schools have established for services. There's recent studies, and this has not been published yet, but there's a colleague of ours in Miami in the United States who has been researching how successful individual education plans of school-based services are for childhood survivors of brain tumors and leukemia. And what his group has found is that annual monitoring of an academic plan is not associated with the best success. So that basically if you wait a whole calendar year or a whole academic year and let that go by without reassessing your child's progress and reassessing how effective those accommodations are, you may miss an entire, 9 months where a child is not making sufficient progress. And so his team found that if you actually look at the success of where your child is and the accommodations that are existing quarterly instead of annually, so every 3 months, someone meets as a team to say, how much progress has this child made in this amount of time? What changes should we be making now to make sure that there is continued academic progress through the remainder of this year? that is associated with better success. I think what I imagine is frustrating to me as a provider, and it must be frustrating to parents, is that right now the onus is on the parent to drive a lot of these changes unless you have an extraordinarily helpful school-based system. And so often this puts the parent in an incredibly critical role as an advocate for your child and as someone who has to push for these changes. I'm not sure how to change that right now, but that is something that parents can be effective advocates if you have the information that you need to be able to make these changes. So I think just knowing that you can ask and say, can we have a meeting about this? Can we change things? I'm not sure it's working. Maybe something that will help you push for those changes in your school. So the Americans with Disabilities Act, it's legislation in the United States, prevents discrimination against any individual who has an identified disability. This is something that applies to people who have had cognitive changes, and it is usually something that is the idea or the educational act that applies to children with learning disabilities kind of trumps the ADA, and ADA is secondary legislation. But as children go through into college, that is where the ADA, or the Prevention of Discrimination Against People, Adults, and Other Individuals who have had changes like that, becomes vital. That is the legislation, if you're in the United States, that will serve as a protection for your child in college and beyond. So that's incredibly important. So I also want to talk about pharmacotherapy. What we know is that this is using medications to treat these cognitive changes that happen and the problems that they can cause in school functioning or home functioning. We know that not a lot of these medications have been tested specifically in cancer survivors so far. Stimulant medication like Ritalin or Concerta, medications that are typically used for children who have been diagnosed with attention deficit disorder, are the ones that have been most extensively studied in children who are brain tumor survivors. And there are some new medications that are being tested currently. You'll hear in talks tomorrow and I think probably elsewhere about 2 studies that are going on specifically for brain tumor survivors and using a medication called modafinil. And this is a medication that has been used to treat narcolepsy or falling asleep suddenly. And the 2 studies that are being used are, one is to examine whether modafinil can effectively treat some of the cognitive changes that happen, and the other one is for children who have survived brain tumors who look like they are really, really sleepy all the time, so excessive daytime sleepiness. The other study is what is targeting kids who are very, very sleepy or just look fatigued, and both of those studies are currently open. And again, we've also seen that omega fatty 3 acids is something that seems like it's coming down the pipeline to look like. This has shown something that has been fairly recently studied among children who have attention problems, and this is something that has been proposed to study in brain tumor survivors, but no one has done it systematically yet. So I want to just talk a little bit more about stimulant medication. People have lots of strong reactions when you talk about using stimulant medication to treat some of the cognitive changes in brain tumor survivors, and I think the best way of addressing that is simply giving you the information that is out here in the literature so far, and then allowing parents to make decisions with their physicians. But we know that stimulant medications is associated in brain tumor survivors with increases in their ability to sustain their attention over time, their processing speed, which is helping them to move a little more quickly and more efficiently, and in their short-term memory, so their ability to just keep information in their minds for a very short amount of time. We know that children who were older when they were diagnosed and treated, and children with higher intellectual functioning, and for some reason boys, respond better to this medication than girls do. However, even though we see improvements in these processes that are very, very important for learning, in the longest trial to date, which looked at children over 1 year of stimulant treatment medication, what we didn't see was a lot of gains in academics. So First of all, this is actually what happens also in children with ADHD, is that we can't really see how treating with stimulant medication increases their scores on math and reading and science. And it may just be that we don't follow kids long enough to see those changes, or it could be that the medication really helps with some of these basic processes but doesn't really lead to improvements in academics. So this is a concern. Yeah?
Pardon me, if there's a likelihood that the brain damaged child isn't being streamed through an appropriate mode of education in general, then how do you know that the drugs are not effective?
Well, you're exactly right. There's probably more than one way. You're exactly right. So I think about, when I think about intervention, I think we're probably going to eventually have to have many different interventions. Medication may be one of them. It may not be effective, but you're right. It could be that if you don't have an effective educational system, in the first place, it would be very hard for the medication to show up in improving those academics. You're correct, and so it could be more pronounced in an individual child. You're exactly right about that. We just don't know. I would say that we don't know about this over time, but that is certainly a reasonable theory. So the other thing is exactly what we're talking about. We don't know that stimulants work over the long term because people haven't studied it in brain tumor survivors yet. We know that for children who have ADHD, there's a little bit of conflicting evidence about how well stimulant medications work over time. So I would say this is a really big unknown right now. We know that behavioral and medical side effects for some survivors seem to be, or some survivors seem to be a little bit more sensitive to the behavioral and medical side effects associated with stimulant medication. And that's been shown, I think, very nicely in the studies that have been done to date, and especially at higher doses. So it looks like survivors may need lower doses of this medication to achieve a benefit than other children who have not had a medical history of cancer. The biggest thing that we found, and I was on my postdoctoral fellowship, I worked on one of the earlier trials of stimulant medication. What we found is that a lot of parents just said, I really don't want my child to take another medication at this point, if at all possible. I think that that's totally understandable to me, particularly if you're not sure if the medication that you're going to add on to your child's regimen is going to be effective. But I would say that, you know, again, we're trying to make parents feel more comfortable about the choices that they have by adding to the information. So a second interventional approach is called cognitive remediation. It's also called neurorehabilitation, which is a mouthful. But it's basically using or adapting strategies that have been used for many years for children who have had a traumatic brain injury, such as having a car accident or a fall. And we have adapted these techniques to be used for children who have acquired changes after treatment for a brain tumor. These methods are very, very well tested in other populations, so they've been around for a really long time, but it's only been in the last 10 years or so that they've been started to use with survivors of pediatric cancer. I would say that also, and this is an area of my expertise that I'll talk to you about, is how we can use technology into cognitive rehabilitation efforts. So the best tested cognitive remediation program was one that was developed by Bob Butler, who is now in Tennessee. He used to be in Oregon. And he developed a program that took a lot of the pieces that had been successful in treating children with traumatic brain injury and wrapped them up into a program that he tested in a nice randomized design. So children completed this very intensive program, which was about 2 hours a week for 6 months. So it was a lot of commitment on the part of the families. And he had 15 sessions specifically targeted at this idea of problem solving or being flexible and that part of that executive function. So that's a really nice piece to this cognitive rehabilitation program. So what happened is that about 60% of the kids completed all of the sessions. So I will tell you, I find that a little bit problematic because it means that 40% of the people didn't complete the sessions, and we have to question, why was that the case? But of the kids that completed this, we saw gains in achievement, attention, memory by these participants. though many of these were sort of on the small side, so it wasn't a gigantic leap forward, but it was movement in the right direction, which is extremely important. And then there was significant improvement in writing and social skills, also incredibly important. Our problem is again, not everybody finished the treatment, and so we're left with the question of, were these the kids that weren't getting any better who decided it's not worth our while to go to this clinic twice, for 2 hours a week for all of this time? It could just be that these kids were the ones that their parents weren't seeing any changes. At best, I think we can say that that level of intensity may not be right for everyone. It may not be practical for people who live a really long distance from a clinic. And the other thing is we know that not every hospital is able to offer this type of intervention. It's just simply not available everywhere because you have to have expertise in being able to deliver this treatment. So because this is a really promising area of intervention, and several years ago, I waited for this results of that trial to come out, and I got very excited about elements of that trial, but trying to make it a little bit easier for parents and families to perform. So I think what we are looking for is an intervention that improves cognitive functioning, not just compensating for problems like letting kids sit up front or giving them some modified work, but we want to fix the problem if at all possible. And we want to target those things that we know are problematic across survivors and that also lead to further changes, like problems in attention and working memory and processing speed. We'd like it ideally to not be any risky in terms of physical side effects, and it would be great if you could do it at home and on your own schedule. So this led me to look at computerized cognitive training as a potential intervention for children who have survived cancer. And this is basically taking those traditional rehabilitation tasks and translating it to a computer format. And this is really nice because you don't have to come to clinic as much. You can practice intensively these exercises in the convenience of your own home. And kids also are just more familiar with it. It looks like a video game, so kids are a little bit more receptive to doing it. The disadvantages right now is that we don't know very much about it at this point. We don't know how effective it is. And this is always my primary concern is if we're going to have an intervention, we'd like it to be effective. In addition, the cost, and if you're Canadian, this stuff that I'm going to be talking about actually is covered by your insurance plan. It's not in the United States. So what this means is even though the cost is moderate compared to a lot of the other treatments that we can offer for children, if you have to pay the entire thing out of pocket, that means that it's less cost effective for families. And in addition, the programs at this point are not well regulated. Cognitive training is not a medication, so it's not regulated by the federal government, which means that if you Google, computerized cognitive training, you're going to get 1 million different products, and most of them have not ever been tested to see if they're effective. So the very first study that I did was a program that was very, very small. This was a pilot trial that, several years ago that I just managed to finally publish of a program that was called Captain's Log. It's published by a company called Brain Train, and the founder of the company is big into Star Trek. So that's why it's called Captain's Log. And this is 33 computer exercises that target a lot of the things that we really want to. Processing speed, problem solving, attention, memory. And so what we did was we sent kids home and we said, please try to do these activities at home at least an hour a week for a few months. Then the critical thing that I want to imply about this is that you have to, if you're doing this as an intervention, the exercises can't just be fun. They have to get harder. So I liken this to doing an exercise program, where if you said, I'm going to really do an exercise program and I want to get fit, you couldn't just go to the gym and set the treadmill to 1 mile an hour and never increase it. If you're not sweating and working out, it may be better than doing nothing at all, but you're not increasing your fitness. And the same is true with the idea behind cognitive training. You have to push yourself and make it harder and harder so that you're constantly pushing your brain to think harder. And that's what's important about this and other of the tasks that I'll talk to you about. So I'm just going to very briefly present this. This is parent ratings of inattention, and I guess I'll just walk over and show you. In this, lower scores are better, so this is a parent rating form, and what we see is that without telling you the scale, scores up here are considered to be clinically significant. These are problems that kids are having that are interfering with their daily lives. And so if we look before treatment, we see that kids are really impaired. If we look after treatment, we can see that that scores are falling a little bit, indicating some improvement in parent perceived inattention. And then 3 months after treatment and doing nothing else, we see that the scores have fallen into the average range or into a typical range. I'll tell you, this looks good, but I'll tell you some issues that I have with this in just a second. We also looked at performance-based measures. So in this case, higher scores are better. And so we say, okay, working memory is one of the things that we hoped would be targeted. And what we can see is that before treatment, working memory scores were a little below average for this group. After treatment, they increased. And 3 months after completing a treatment, they continued to increase. So again, and this is now back into the average range for these kids. So the good news is that in this very small study, we had 9 kids. We did not use a randomized design. I really just wanted to see if kids could do this because nobody had done anything like this before. So we saw that more than half of the kids saw improvements in both parent-rated attention and working memory after doing the treatment. And nicely enough, the kids that worked the most at the program had the biggest gains. So this is also makes sense, right? You would hope that the people who worked out the most, had the best gains in their fitness. And then kids that had the most impairments at the beginning also saw the biggest gains. So this also makes sense. The problems that I have with this, I'll keep on this one since I deleted my problem slide. The problems is that, first of all, it's an extremely small sample. We didn't randomize kids to one arm or the other. And when you ask parents of kids where you know that your child has done an intervention, part of the changes that we see over time might just have been like parents really hoping to see changes in their child, knowing that they've received an intervention. So, and it could also just be that over time those problems were going to get better anyway. And it's nice that on our performance-based measures, when we actually measured working memory in the clinic, that those also got better, but there's also a concern about kids just getting better because they're practicing the same task again. And not all of those gains that we saw could be attributed to just getting better by practice, but still we need a better, well-designed trial with more kids to be able to confidently say that that's something that's going to work. So hi, I'm running out of time, so I'm going to go fast. I'm not the only one who's doing this work. There's also been an additional program, and I just want to point this out for you. It's a program called Lumosity, L-U-M-O-S-I-T-Y, Lumosity, and it really is more for adolescents and adults, but there is some empirical support that this is a program that can be successful. It's only been studied in 23 survivors of brain tumors or leukemia, initially, we didn't see any improvement in that study on performance-based measures, but children also participated in scanning, looking at activity in their brain before and after treatment. And what we found is that in areas of the brain that we know are involved in working memory and executive functioning, there was increased activity there. So it may just be that we didn't allow children in this study, and this is not my group, but they didn't allow children to practice enough to get the effect where we could detect it by our measures in the clinic, but that something was already happening in the brain. Again, very small sample, so we're not sure yet, but this is something that's promising. I did an additional study where I did a randomized design using a different program and with brain tumors and leukemia survivors that were school-aged and who already had problems with their learning and memory. And we used a program called CogMed, and this is a program that is also available. You can learn more about it at a site called www.cogmed.com. And what we found is that similar to the other treatments that we did with computerized training, that we had most people fully complete it, which is important because to me that says that, hey, if you allow kids to do things at home, then they're a little bit more able to comply with the treatment. We didn't get any adverse effects. The nice thing about this is that simply practicing a computer program at home isn't associated with any side effects that we know of, and that's important as well. And most people said that their kids liked doing this training program at home. Usually when I do this with kids, I'll say, listen, it's not as fun as a video game, but it's more fun than homework. And this is usually what kids report. So we were happy because we had very few people, less than 20% said that their kids were bored or frustrated doing this program. And that is usually not the case with homework or other similar type of chores. So what we saw, and I'll show you the little graphs here. So we had a treatment and a control group. The kids who were in the treatment group are in blue, and the control group is in red. In this case, higher scores are better because it's measuring working memory abilities. And what we can see is that the groups were really similar before they started the treatment. And after they did the treatment, the group who actually did the training had their working memory scores improve significantly more than the group in the control group. So both of these groups were doing the same tasks over and over again, so we would imagine that if there were practice effects, both groups would have them the same. But because the treatment group increased on these scores, and this is just an indicator of how strong the treatment effect was, and what we liked also is that even after 3 months of doing no more training, the differences were maintained between these groups. It was similar for parent-rated attention problems. I'm going to go really quickly through here. So after training, people in the, remember, these are lower scores are better. So this is nice that the blue group drops. And there were a trend, or what we say, not quite significant, but a difference that looks like it might be significant if you had more kids, of parent-rated learning problems to improve. But it wasn't true after 3 months. The groups kind of evened out a little bit more. So I just want to end by talking about what we're doing now, and I think that this is the most important thing and the stuff that I get very excited about. First of all, computerized cognitive training is being examined further in 2 other trials, both using brain tumor patients. My colleague at St. Jude, Heather Conklin, is studying a larger sample. She's also looking at brain-based changes by having children participate in scanning before and after. Bonnie Carlson Green in Minnesota is doing a study exclusively on brain tumor survivors, and she's looking to see if brain tumor survivors have with a bigger dose of the training, get more improvements. So she's asking them to do the cognitive training longer at home, and she's going to see if that makes a difference. Yes. Bonnie Carlson Green, so her name is right up there. Her first name is Bonnie, and she's in Minnesota. That study is going on right now. And the other thing that we're trying to do right now is to see if you can possibly do anything with cognitive training before the changes occur. And so we're doing 2 studies right now where we're looking at training during treatment to see if kids are practicing these cognitive skills while they're receiving radiation or chemotherapy. Does that delay any of these changes from occurring later? So we're going to be doing a study starting in the fall of children who are newly diagnosed with brain tumors and receiving radiation therapy, and we're going to ask them to do this cognitive training immediately after radiation to see if that changes in any way the development of cognitive changes over time. We don't know that it will, but we're going to start looking. And finally, I just wanted to mention that other people are looking specifically at math. And Ida Moore, who is in Texas, is looking at a math intervention while kids are undergoing training to see if doing math, intensive math, which involves problem solving, attention and working memory, sort of secondary to learning math, and if this helps kids also prevent or delay changes over time. And the nice thing is that when kids did quite a lot of math concepts, 40 to 50 hours over a year, they had significant effect on achievement and math scores over time. So basically, they were learning better in school by having this intervention during treatment. So this is a really important, exciting intervention that we will hopefully see more of over time. Yes? These computer programs? Yeah. Do you have to be able to see to use them? Yeah, that's a great idea, or great question. You do have to have vision that's sufficient to see and use a computer screen. So we have currently in our studies, we have children who have had optic nerve gliomas that have had significant vision loss, but they're still able to have enough field of vision where they can see the computer screen, and they are able to do the computer program. But I would say that if you have no vision at all, you would have to really limit yourself to the auditory component of the computerized programs. And there are some programs with a greater, auditory working memory process to them. So there are some tasks in the CogMed that are auditory, and you could arrange with your provider to just turn on those aspects of CogMed. I would say that the Brain Train Captain's Log program has a bunch of auditory tasks to them that might be good as well, and that one you should be able to just purchase and use at home, and you just might need a little bit of guidance in how to set up the program so that you're only doing the auditory-based tasks. Yes? Yes, okay, so as I said, Brain Train, the company is Brain Train, the computer program is called Captain's Log, and that one should be available for purchase, although you can also do it with a clinical provider. CogMed is, and I must have accidentally deleted my CogMed slide, but there is, you have to use a coach with it. So CogMed has a coaching program, basically like a personal trainer, somebody who wants, who is talking to your child every week by phone saying, hey, look, I looked at your training data available through the internet, through the web on a server, and I saw that you were kind of pooping out at the end of your training yesterday. Here's an idea I have about the next time that you're doing this at home to maybe give you a little more motivation or a little more effort. And so you have to do that through a practice, but it is available. And as I said, if you live in Canada, it's covered by insurance. This is what I was told. Yeah. And it's what? CogMed. CogMed, and it's www.cogmed.com. And you can. What's the range of age group? Ah, that's wonderful. The age range is from 4 all the way on up to adulthood. So you can, they have a preschool version, a school-age version, and an adult version of that program, all available.
My daughter is an adult right now. Who can help me to find all those programs? Where should I go?
Well, again, going to the web is good. I'm happy to write things down for you afterwards. Okay, I can write down what these are and where you can go, and you might have to do some searching online for a provider, but you really should be able to find some of these. And the Lumosity program is really appropriate only for older adolescents or adults, but that one should also be available online.
What I do with my daughter, I buy her little books with math and with language, grade 2, 3, 4, and she does on the subway, on the bus.
I think doing anything at this point is anything that you can do to keep your child active and exploring all of these areas that we talked about is not a bad idea, unless they're really giving you resistance about doing those type things. I think exposure and practice on any of these skills is really important. So one thing that I wanted to end with, and I know that I'm over time, is that obviously parent advocacy, being an advocate for your child is maybe not something that you ever wanted to do or that you think you should have to do continually, but it is critical. It opens the doors to services, and particularly interfacing with the education system is going to be important over time. And I think just even asking your providers, is there anything else we can try, is going to be important as you move forward. And then finally, I just want to leave with a message of hope. There are many, many people who are working on this. I'm excited tomorrow because somebody right here in Toronto, Dr. Dawn Mabbitt, is doing an exercise intervention, which I'm very excited about, and we're going to hear about people who are doing all kinds of interventions specifically aimed at increasing the quality of life for children who have survived brain tumors, and I think it's an exciting time. Keep hope. I know that effective interventions are coming over time. And thank you.